So surgical workup in the CLI, what I want you to know as well, again, no disclosures. I think we're all compelled to approach the same way everything. I think we can all agree that a tailored approach sometimes will reap benefit for patients and healthcare providers or systems as well. In our program, we've been doing this for a while, and we stratify patients who present with PAD and ischemic tissue loss in 4 different intention to treat categories. And this is predicated on the fact that the conservative group of patients have mild ischemia, and we believe they'll be able to heal their tissue loss with wound care management alone. We have patients who do have indeed palliative limb. They have comorbidities that we believe they are going to bring mortality before limb-related complications. We still have a role for primary amputation in some settings with extensive tissue loss, pedal sepsis that requires this articulation at the ankle level, and the revascularization group, which is, of course, the central group on our program. Now, once you establish revascularization is beneficial, we need to establish the candidacy for that. Is it risky? Is it not too risky? And of course, there's going to be patients who are favored bypass, favor endovascular, and there's obviously an equipoise as well that is currently being studied. So what constitutes a candidate for revascularization? In our opinion, we use the acronym PAL, patient, anatomy, and limb, and the health profile, the burden of disease, and the limb presentation are all variables we all compute in order to make that decision-making tree to arrive to the what type and procedure, what will be the safest thing for the patient. And as Dr. Farber has always told us in our best CLI meetings, you have to fight your bias. And scientific bias is hard to fight. We've been trained, we have successfully used it, so you have to really overcome that in order to be open to what is going to be the best modality. Having said that, there is some established literature, although there's been some shortcomings of these studies. The BASIL trial have proven that in those patients who have a life expectancy more than 2 years, revascularization with single segment greater saphenous vein continues to be superior to BIP in those patients because of the durability and the reduced intervention rate. Best CLI, I don't have anything else to do but to say that 2 PIs are right here and they'll explain how the trial is going. But an old professor of mine used to say every patient is a surgical patient. Now, having been humble in this meeting, I think I've seen that probably every patient is an endovascular candidate as well. But some are just better than other ones, aren't they? So for us, we ask ourselves, what can we do to make the perioperative procedure safer for bypass surgery, and do these strategies actually have an impact in the overall survival? And it's all about selection, in my opinion. So there is data for PREVENT 3 trial that has given us the ability to stratify patients. There's also another tools from CRAB that gives us, again, the ability to stratify patients surgically into moderate, mild, and mild, moderate, or severe risk for predicting mortality and morbidity associated with bypass surgery. What about this correlation between CLI and CAD? Prophylactic CAD intervention can have an impact in making the operation safer, since cardiac disease, cardiac events are actually a major contributor to mortality in bypass surgery. Well, this has been answered by the VA cooperative trial that have randomized people who were receiving aortic or peripheral vascular surgery, and in those patients with multiple cardiac risks or positive stress tests were workup with coronary angiography. Based on the angiogram results, a significant CAD was seen, and they were candidates for revascularization. They were randomized either to direct vascular surgery or to PCI or CABG, and then vascular surgery after that. And the data showed there was no perioperative advantage nor 2-year survival comparing these 2 modalities. So I think we kind of answered the question whether peri-procedure or pre-vascular procedure coronary intervention will actually be safe and effective in predicting and decreasing cardiac complications in bypass. On the issue of beta blockade, we've been up and down over the years. In the most recent meta-analysis from the British Journal of Anesthesia, they really don't recommend utilization of beta blockade in vascular and endovascular patients. About platelets and statin therapy and its perioperative actions in terms of protecting the patients. Again, large VQE research showed, again, no influence on perioperative MI or stroke rates. Statins were also studied long-term in terms of graft and amputation-related events, and neither of those two were actually influenced by statin use. What about the type of procedure? To my surprise, the basal trial did not actually confirm the bias that endovascular had a mortality superiority over bypass. It may be a power issue, maybe a selection bias issue. Nevertheless, it did not. It did, of course, correlate with a safer profile in terms of morbidity. So there's no doubt that endovascular is superior to bypass first strategy in regards to that particular metric. What about the impact on overall survival? We talk a little bit about statins long-term, and they do indeed influence long-term survival in patients specifically with critical limb ischemia. And the Society of Vascular Surgery, in a recent publication as well, endorsed the utilization of antiplatelets as well as statin therapy overall in every vascular surgical patient who receives surgery, estimating the 5-year survival when those two medications are used up to 82%. So once we're done with all these strategies about patient and patient safety and procedural safety, we also, of course, evaluate the limb. And the limb, the SVS Wi-Fi classification is the one we use, and again, it was very, very eloquently described yesterday, and allow us to stratify these patients in mild and clinical different categories and clinical stages. And these clinical stages have been correlated to amputation, to survival, as well as to wound healing overall. So practical knowledge, what do we do on a daily basis, putting all these things together? Well, the first thing we do is determine if the patient has infection. If the patient doesn't have infection, that's great. If the patient does have infection indeed, we need to take care of the infection regardless of the ischemic profile. Now, how you do that depends on the classification and stratification of the infection itself. You always want to make sure there's no bone component of the infection picture as well. Once you're done with that, we published this many years ago. We tried to use this criteria to establish this best intention to treat algorithm of care. And again, most of these patients will actually be receiving revascularization when they have severe ischemia, defined as TCPO2s less than 30. We have this conservative group of patients. We have a research investment on them when they have a TCPO2 over 30 plus other features. And we have approximately 70% success rate on wound healing by pedal ambulation, freedom from amputation, almost 95% of the time. So once you are a candidate for revascularization, we will evaluate your anatomy with the usual modalities we use for all these patients. If it's suprainguinal disease, we'll start stratifying with a CT angio. If it's infrainguinal disease based on a physical examination and et cetera, we will proceed directly to angiogram in general. So revascularization is safe and beneficial. We will stratify the patient, and that helps us to talk to the patient about the safety of the procedure overall. We will use the white classification in terms of the outcome expectations. It's all about expectations with this type of patients. We will use pre-procedural coronary evaluation if they have low EF, if they have active angina or MI, or they have severe aortic stenosis. We do not use anti-beta blockades de novo, but we will continue them if they're receiving them, and we will use aspirin and statin therapy in order to improve their overall survival. Last slide will be that really, again, tailored approach to these patients is what we consider the best workup. Thank you very much.